All right, welcome everybody. My name is Kim Dorman and I serve as the Community Engagement Coordinator for the Princeton Public Library. I'm grateful to you all for being here this evening. We are really excited to have Dr. Sheila Vakharia here to talk about her book, The Harm Reduction Gap, as part of the Mayor's Wellness Campaign. I wanted to tell you a little bit about the Mayor's Wellness Campaign that we're doing in collaboration with the Municipality of Princeton. It's a statewide community health initiative that provides evidence-based tools and strategies for mayors and community leaders to help their residents achieve healthier lifestyles and to improve overall health and wellness in their communities. The New Jersey Healthcare Quality Institute has been leading the Mayor's Wellness Campaign in partnership with the New Jersey State League of Municipalities since 2006. Um, and one of the main themes this year was harm reduction for the Mayor's Wellness Campaign in Princeton. And when we learned that earlier this year, the library was thrilled to find Dr. Vakharia's book, The Harm Reduction Gap: Implications for Our Communities, because it's precisely at the intersection of the kind of work we're trying to uplift. And particularly, her background is in social work as well as her doctorate, and so that's also in alignment with a lot of things that the library is doing, and working to help community members. Dr. Vakharia is an author, a sought-after speaker, and a national expert on harm reduction and drug policy. She is currently the Deputy Director of the Department of Research and Academic Engagement at the Drug Policy Alliance, the nation's leading advocacy organization fighting to end the war on drugs. Dr. Vakharia brings over 15 years of combined experience in clinical social work in both treatment and harm reduction settings, research, teaching, and policy advocacy to her work. She's also wonderfully approachable. I'm really excited that you're all going to get the chance to hear from her. I really enjoyed the last 15 minutes where I got to learn a little bit more about your background and your work, and thank you for everything you do.
Thank you. Thanks so much for having me. Hello and greetings and welcome to all of you who are with us live tonight and to all of you who will be watching this in the future. So the title of the book is actually The Harm Reduction Gap: Helping Individuals Left Behind by Conventional Drug Prevention and Abstinence-Only Treatment. But given that this is a bit of a community talk, I kind of modified the title a little bit, but hopefully listening to this talk will inspire you to think of ways to incorporate harm reduction in your communities and in your homes and in your work, and maybe pick up a copy which is available at your library. And an audiobook has just been made available, which I narrated. So I highly recommend that too. So my goals for today's presentation are threefold. So I want to summarize the key elements of the current approach to drug prevention and drug treatment across most of the United States that I believe has created what I'm calling the harm reduction gap. I'm going to explain how drug criminalization, or the war on drugs, created this harm reduction gap and contributed to the HIV/AIDS crisis that impacted and impacts people who inject drugs, but also the current overdose crisis that we're in. And then I'm going to describe the 6 key harm reduction elements that I believe should be incorporated into our broader continuum of care to meet the needs of our communities and to close the harm reduction gap. So this big kind of image of a bubble is meant to represent the United States population of folks over the age of 12. According to the National Survey on Drug Use and Health, which is an annual survey conducted by the Substance Abuse and Mental Health Services Administration, they find typically on any given year that roughly about 70% of people over the age of 12 report having used alcohol, tobacco, nicotine, or some illicit drug in the past year. And what this annual survey typically finds, because it's been conducted since the 70s, is that a significant portion of people who've used any of these substances in the past year had likely used them in the past month as well. And it's estimated that about 58% of people over the age of 12 used one of these substances in the past month. Now, if you zoom in even further and look at folks who might meet criteria for an addiction or a substance use disorder, as we call it in most medical and healthcare settings, we're talking about 16.5% of the population meeting criteria for an addiction. And then when we think about who is it that received treatment or how many people received treatment in the past year, it's estimated that about 1% of the population received treatment in the past year. And the reason why I always try to start my presentations with this is to say, first of all, that, the line between legal drugs and illegal drugs, which I'll be getting into over the course of this presentation, is the murky one. But truly, these are all mood-altering substances, right? That are used sometimes for medicinal purposes, sometimes for recreation, sometimes for productivity, and euphoria, and a variety of other reasons. And that, we as a society and as a culture, in the United States are not that unique in the fact that we use substances to change how we feel. And when you look back historically over the history of human civilization, people have used mood-altering substances for a variety of purposes. And so substance use is not something that those people do. It's often something that we ourselves do, right? And when we blur the distinctions between the legal, illegal drugs, and really get at the fact that we're using substances to change how we feel, a lot of us do this. And the vast majority of us don't meet criteria for an addiction. Most of us use these substances occasionally, socially, or recreationally. And there is a small subset of us who may go on to experience more harmful or negative effects associated with it to meet the criteria for an addiction. But many of us use substances in our day-to-day lives, right? And that the majority of people, even of those who have addictions, will not receive treatment in any given year, right? And just to kind of add to this, right, estimates suggest that 1 in 5 deaths can be traced to tobacco use in any given year, even right now. Even though rates of cigarette smoking and tobacco consumption are at lows, at historic lows, we can still trace 1 in 5 deaths to some form of tobacco use in the past. And we lose hundreds of thousands of people every year in the United States to alcohol-related causes, whether that includes cirrhosis, a variety of cancers, but also through drunk driving and other kinds of accidents related to their alcohol use. And as many of you are well aware, we've lost 1.1 million people to drug overdose in this current drug overdose crisis that we've been in since the early 2000s, right? And in this past year alone, we lost over 105,000 people to overdose. And since COVID started, we've lost over 100,000 people a year for several years in a row now. But the other thing I want to acknowledge is that countless other people experience day-to-day drug-related harms, including, getting behind the wheel after having a drink, or getting into an argument or a fight with a loved one, experiencing depression or anxiety, having a hangover that means you don't go to work that day, or even potentially getting sick, right? So, even if you don't meet criteria for addiction, even if your drug use doesn't lead to an immediate cause of death, there are risks that are associated with putting substances in your body. And many of us experience consequences and harms, many of which can be debilitating, but some of which can just be inconvenient or could have been avoided or prevented if we had the skills, the tools and strategies to do so. And just because you don't have an addiction or meet criteria for addiction doesn't mean you may not experience a drug-related harm, right? And so what is it in our continuum of care right now? What do our options give us? And what does our public health infrastructure and treatment infrastructure look like when it comes to drug use in this country? Well, on the one hand, we've got drug prevention. And I don't know how many of you watching are fellow millennials, but I am a child of the 80s, and in the 90s was a DARE kid. I grew up with a DARE officer coming into my classroom, talking to us about drugs. He opened this big glass case, and in it were all of these kinds of pipes, and there were syringes and pills and powders and little baggies and things. And the message was really clear, this is what drugs are, don't do them. And we were told if we used any of these drugs that it would lead to insanity, death, and a life of criminality. We were told if we ever used a drug like marijuana, even though it seemed like a simple, harmless drug, that it could lead you to using drugs like heroin. And that as a young person, we should commit to abstinence. There were essay writing competitions in many of our DARE classrooms. There were different kinds of activities and coloring books and contests. And, we were, as young people, told that drugs are bad. They lead to these horrible lifelong consequences, and you should never do them, right? And we were just told, just say no. And while it might have been a well-intentioned message to give to young people, because using substances before you have, a fully developed frontal lobe and decision-making power, and, the ability to reason and to kind of weigh pros and cons and risks and benefits, like it's probably not the safest thing to do. We weren't actually given any changed or different messages as we got older, especially as we got closer to becoming legally of age to, for instance, smoke cigarettes. Many of us were 18 when we were still in school, and there were people who were smoking cigarettes. And within a few years of graduating high school, we would be legal and old enough to drink alcohol. And that just say no message really didn't set us up for being prepared when many of us did eventually go on to use the legal substances we were allowed to use, but also for those of us who went on to use illegal drugs, right? So this just say no message, although well-intentioned and well-timed for younger people, often hit an expiration date as soon as we were of age, or even as soon as we started experimenting. And unfortunately, because we were never given any information about how to stay safe in a world with drugs, where we might occasionally or socially use drugs or use them more frequently, we often had to just learn for ourselves how to stay safe, right? And the rest of our continuum of care really had nothing else to offer us when we went off to college and started drinking, and sometimes we're binge drinking, or when some of us went on to use other different drugs that were illegal, right? And the only thing that our society has to offer folks who go on to use drugs of any kind is our traditional abstinence-only drug treatment system, right? And even that drug treatment system is only set up for people who already meet criteria for an addiction. So our treatment system isn't meant to be a stopgap for people whose use might be becoming more risky, or for people who want to keep themselves in check around their use or develop strategies to stay safe. Our system is only built for people who already meet criteria for an addiction, who have experienced repeated negative consequences and harmful effects because of their drug use. And what does our treatment system say? Well, from the moment you walk in the door of our treatment facility, that you must commit to abstinence. And I know this because I worked in a 12-step abstinence only treatment facility myself. And so that is our current continuum of care. Basically, with the intention of preventing future drug problems, telling young people never use drugs, with the hopes that you never will use a substance, and then you can't develop a drug problem if you've never used any of these substances. And then if you do somehow go on to use these substances and you develop a severe enough problem, you can walk in the door of a treatment facility, but the only solution they're going to offer you is an abstinence-based approach, right? And so I argue that that break and that gap in our system is a harm reduction gap, because there are so many other possibilities and touch points and strategies and interventions we could have had along the way in that middle ground that don't generally exist for a lot of people across the United States and across the world, right? And because what about those people who say yes to drugs, legal ones and illegal ones? And as I just said in my last slide, 70% of people used one of these substances in the past year, and 58% of people used any one of those substances in the past month. And they could have been getting tips, strategies, and tools to stay safe. But really, we just kind of say you're on your own when you use substances. We're not going to really be able to give you a lot of support around it unless you develop a problem. And then we're going to tell you to quit. And, the other question that it lends us to ask is, what about those of us who don't want, need, or seek treatment? Another thing that survey that I introduced earlier finds in any given year is that about 90% of people, even those people who meet criteria for an addiction, will not walk in the door of a treatment facility in any given year. And so, what do we have to offer people who are the occasional social recreational user to stay safe? Because a lot of harms can be avoided and prevented if they could just learn how to stay safe and implement some of those strategies. But also, what about those 90% of people who actually meet criteria for a drug problem, but aren't going to walk in the door of a treatment facility? There's nothing else for them because the treatment facility is the only place where they could go. And what if there's a waiting list? What if the nearest facility is hours away? What if they don't provide tailored services to meet your needs? What if they don't have evening hours? What if they don't have childcare built in? A lot of people don't seek treatment. So what do we have to offer them? And I say that they're falling in the harm reduction gap because these are the prime candidates for a harm reduction approach and for harm reduction interventions. So before I go too much further, what is harm reduction? Harm reduction is a set of practical strategies and ideas aimed at reducing the negative consequences associated with drug use. And that's a definition provided by the National Harm Reduction Coalition. And harm reductionists know it is possible to arm those who use drugs with the tools and skills to stay as safe as possible right now while they're using those drugs. And they believe that it is far more practical and realistic to help people in that moment than simply hoping just that people who use drugs can figure out how to stay safe after they outgrow the abstinence only messages of their youth. I mean, how many of us have heard horror stories about young people going off and binge drinking, and their friend is clearly blacked out and they put them in a shower to try to wake them up? Or they say, oh, he just needs to sleep it off, right? And so many times that's not going to sober someone up, and that could actually put them at risk for more harm, right? And so we can't leave people and trust people, especially now in this moment where our drug supply is increasingly unpredictable too, and people experimenting, thinking that they're just using a pill from a friend who got it from a prescription, but it actually might be a counterfeit pill, and then all of a sudden having an overdose and their friend not knowing how to respond, or that this person actually needs CPR or to be administered naloxone so that they get revived. So, we can't just always expect that people know how to respond in sometimes these really, scary and dangerous and life-threatening situations. So, and also what I think is really important is that harm reductionists are willing to help people who have substance use disorders or addictions without fixating on abstinence as a prerequisite, because sadly, our treatment system mandates usually abstinence as a goal, and then they require you to start abstaining from day one of being in treatment. And if you continue testing positive for drugs, you will get terminated from treatment for noncompliance. And so it's this expectation to commit to a goal of abstinence, but also if you don't achieve abstinence very quickly in these treatment systems, you will be terminated and then no longer connected to anyone for services at that facility. And so harm reductionists are there to say, even if you can't commit to abstinence, we still want to see you and we still want to support you. And there's many ways that we can try to be helpful to you. And so why is it that harm reduction approaches are not the mainstream approach right now already to risky drug use in the United States? Why is it that states like New Jersey and New York, where I live, are doing a better job of expanding access to harm reduction now? There's public health funds that are allocated to all these kinds of programs. But why is it that, our states are more exceptions than the rule? Because there are entire states, 20% of states in the country, where giving someone a sterile syringe who uses drugs is illegal, and that it's a criminalized act to both give it or for that person who uses drugs to possess that syringe, and they could be arrested for it. Why is it that this isn't the mainstream approach to how we help people who use drugs? And I would argue, and what I argue in my book, is that the key reason is the war on drugs, drug prohibition, the criminalization of drugs. In that, when we first started to criminalize drugs, we laid the foundation for the harm reduction gap and created the conditions that would later lead to policies being passed that would make it harder for people who can't commit to abstinence to get any sort of help in our systems and continuum of care. So now for the rest of this presentation, I'm going to introduce some drug policy history that maybe some of you aren't familiar with. And I'm actually going to read from the book as I kind of provide you with some visuals on my slides to illustrate the points that I'm making. So we can track some of the earliest drug laws by starting with opium in this country. Opium was first imported into the United States in the 1700s. Doctors quickly found numerous applications for this multi-purpose drug since it helped alleviate pain and had promising effects on cough and other kinds of symptoms. And the import of crude opium reached its peak in 1896. It was a common ingredient in many medications and was later processed into the more potent opium derivative known as morphine. Many do not know that heroin was the brand name of potent opium-derived medications that Bayer Pharmaceutical invented, as you can see here. This is a real advertisement from Bayer. And the reason why they called it heroin was because they believed that the pain relief and euphoria of the opiate would help people feel more heroic. People commonly consumed opium and opium-derived drugs in tonics, syrups, or lozenges to treat a variety of health issues, including anxiety and nervous disorders, gastrointestinal problems, respiratory problems, menstrual cramps, and other ailments. And population surveys in the 1800s showed that white Americans from all walks of life were using opiates, including Civil War soldiers, housewives, working men, the educated and the wealthy alike. And during this time, middle-class white women emerged as the dominant consumers of opium products for both psychological and medical issues. Though these drugs were legally available, production and sales were not regulated, so people often didn't know what they were consuming, how much they were consuming, and what the risks might be. There weren't warning labels on these medications at the time. And so it meant that people could easily purchase opiates, but they had no idea what the risks were that they carried. And they thought of them kind of as a cure-all, because as I just said, they were suggested for use for a variety of conditions. And the problem was that because people weren't educated about use, they were developing physiological dependence, meaning that using it regularly was leading them to develop a higher tolerance for these medications. And they were also starting to unknowingly experience withdrawal symptoms if they went too long without using them. And it led people to use more of these substances to alleviate those symptoms. And it was estimated that roughly 250,000 Americans were physically dependent on these drugs by the turn of the 20th century. But despite growing concerns and awareness that there was a growing addiction of these medications among people, there weren't any proposed bans on these patent medications. In fact, the only form of drug use that garnered any sort of scorn and stigma among the American population at the time was opium smoking. And this was because smoking was associated with the Chinese immigrants who came to the United States during the 1850s for the gold rush, but who also eventually came to work on the railroads and in other industries in California and along the West Coast. Chinese people had a complicated place in American society because they were seen as competition for jobs during high levels of unemployment. And anti-Chinese sentiment was prevalent because of their different culture and practices, and they were perceived as threatening the American way of life. Chinese immigrants were frequently subjected to racial discrimination in their day-to-day lives, and waves of xenophobic laws were passed to target and exclude them from privileges afforded to white citizens. And at the time, it was common for Chinese immigrants to visit opium dens where they could recreationally use opium, as was practiced in China. And while most of these dens predominantly served Chinese clientele, opium smoking had a growing appeal to white locals, rich and poor alike. But there were fears about the interracial socializing that would occur at these dens, and some believed that Chinese opium dens would corrupt white women by getting them addicted to the drug so that Chinese men could sexually abuse them. And eventually these fears motivated ordinances that banned white Americans from visiting opium dens altogether. And San Francisco passed the first general ban on opium smoking in 1875, the first anti-drug ordinance in the United States. Over the next several years, other jurisdictions nationwide passed similar laws targeting opium dens fueled by anti-Chinese motives, and this marked the beginning of a two-tiered and racialized approach to drugs. The idea that drug use for health purposes should be accessible and available to predominantly white populations, but racialized others who were sometimes using the same drugs recreationally could not be trusted and were in fact a threat to public safety. Meanwhile, cocaine was first extracted from coca leaves in the 1850s and was introduced to the US soon after. Though the stimulating effects were relatively mild when coca leaves were consumed by chewing or brewing them into teas, cocaine was a far more potent stimulant. And cocaine quickly became popular, and imports peaked around the same time as opium imports did. And it was thought to increase worker productivity because of its stimulating effects. And it was seen as having great medical potential. Sigmund Freud was a huge fan. And as you can see here, cocaine was marketed as a topical anesthetic. Cocaine's cousin, lidocaine, is still used in routine dental work all the time. And so like opium, cocaine was added to beverages, patent medications, and tonics. It was used as a topical pain reliever and a treatment sometimes for alcohol addiction. And the urban myth is true that there were coca derivatives in the original formulations for Coca-Cola. And when those coca derivatives were removed, it became a soft drink. Did you ever wonder why we call it a soft drink? That's part of the reason. And so while cocaine addiction did occur, it wasn't as like widely concerning as opioid addiction because of the physical dependence that's associated with opioid addiction. But you know, there was some fear mongering that was starting to get tacked on to cocaine as well. Cocaine was cheap and its use had spread to the South. And white Americans were becoming concerned about how cocaine would turn the freed Black community into a violent threat, even though at the time, white Americans were the dominant users of the drug. A clear example can be found in this headline. This is a real newspaper headline. And I don't know how big your screens are and how well you can read it, but I will read it to you. But this is an actual New York Times newspaper cover from 1914. And the headline says, "Negro cocaine fiends are a new Southern menace." The article sensationalized anecdotes from sheriffs about supposedly dangerous Black men under the influence of cocaine who became better marksmen and were somehow impervious to traditional bullets. Because of this, law enforcement argued that they needed larger gauge bullets to stop supposedly cocaine-fueled Black men from wreaking havoc. And using the racialized dimension of drug use to stoke fears was not an accident, and it was quite persuasive to the predominantly white public. It did not matter that cocaine use among Black communities was rare, or that there was any way to disprove or prove that the Black men in these stories were actually under the influence of cocaine. And articles like this, along with films like Birth of a Nation, perpetuated the myth that Black men, both on cocaine but also sober, were predators who, in the case of the film, would rape white women when given the chance. In one of the film's most memorable scenes, a Black man chases a white woman to the edge of a cliff, and she ultimately throws herself off to avoid being raped. And I just saw your comment, Janie. And a quote here I have is this: "The fear of the cocainized Black coincided with the peak of lynchings, legal segregation, and voting laws, all designed to remove political and social power from him." From the beginning, drug-related stigma was created and then weaponized to oppress Black communities further and to justify stripping them of legal rights, even as predominantly white populations of cocaine users maintained their legal access to the drug, right? And so, as you can see here, these patent medications were not regulated, right? So they were making all these claims that they were going to help with all these issues. They weren't actually warning people of side effects, and you didn't always know what the label was saying was accurate to what was actually in the product you bought. So There was a positive policy move forward in 1906 when the Pure Food and Drug Act was passed, which said, you have to accurately label what is in your substances. And then eventually the Food and Drug Administration was formed soon after to enforce and regulate and oversee what was in these medications. So this was actually a positive development. However, we also saw coinciding with this push to pass policies to allow for people to know what they're using in their medicines, to now start banning forms of drugs and drug use that was not seen as having medical utility. And so in 1909, Congress passed its first federal drug prohibition law, the Opium Exclusion Act, which banned imports of opium for non-medical use, i.e. for recreational smokers, like the opium smoking that was depicted as a largely Chinese practice, but not the form of opium that was used in medicinal tonics and tinctures by largely white populations, right? And in 1914, soon after this New York Times article had come out, the non-medical use of opium and cocaine started to peak, and it led to the passage of the Harrison Narcotics Tax Act, which was the first federal tax act, which was meant to tax and track medical use of those two kinds of products, but was starting the foundation of restricting access to those drugs federally for any other kind of use, right? And by this time, it was clear that we were already on a policy path to restricting access to both cocaine and opium use eventually. Subsequent laws like the Jones-Miller Narcotics Act of 1922 had fines and prison terms for violators of the Harrison Narcotics Act, so that people were now having a harder time to access these drugs if they couldn't get access within the medical system or with a prescription. And eventually, the Heroin Act of 1924 made all heroin manufacturing illegal, while keeping access to other forms of opiates available, like morphine, for medical use. In 1934, the Uniform State Narcotics Drug Act was passed, and it pressured all 50 states to codify penalties for people who sold, manufactured, or used these drugs for any reason in their states. And the act gave states the authority to enforce these laws within their border. By officially pushing cocaine and heroin out of the medical system and into the underground market, our policies made it so that patients who use these drugs will now join the ranks of those excluded from medical access. And now they were all in the harm reduction gap using an unpredictable drug supply, right? Let's talk about marijuana next. So hemp was already a commonly grown crop among farmers, and it was used to make durable industrial fabrics, clothing, plasters, and rope long before opium or cocaine ever came to the United States. And it is the same cannabis plant that we call marijuana, but it is bred and grown differently from marijuana because marijuana has a higher THC content and psychoactive effects. And so it was not widely recognized as a mood-altering drug for a long time because the prevalent forms of the plant that were being grown were the ones for industrial purposes. But by the turn of the 20th century, just as we were seeing potential uses medicinally for opium and coca-derived products, we were starting to see cannabis extracts used in some of these tonics and tinctures as well, and oftentimes available in combination with them in these patent medications that were being marketed. And as the backlash against opium and cocaine grew, some advocates attempted to include cannabis in early drafts of the Harrison Narcotics Act, yet it did not make it in because it was not that widespread used or concerned among people. And it didn't actually become a concern until later on in the 1900s when some doctors and legislators in the South and Midwest were warning about its habit-forming potential. And like government policy on opiates and cocaine before it, marijuana prohibition eventually gained more support due to xenophobia and fear. So in the 1920s, concerns grew in the Southwest among the southern border as Mexican immigrants entered the country due to the Mexican Revolution and in response to American demands for agricultural labor and support. And I will get to that question as well. And so as we saw the hostility towards Chinese workers, we saw a similar hostility towards Mexicans, right? And what was happening also strategically at the time was that those advocates who couldn't get cannabis included under the Harrison Narcotics Act were thinking of strategies to increase fears and concerns about this drug, even in states where use was not yet a concern for people. And so we heard from Harry Anslinger, who was one of the architects of major policy reforms at the time, a shift in the discourse. And now, from calling it cannabis, which Americans knew of for its associated with hemp and industrial purposes, but also in its association with medicinal uses, to starting to call it marijuana, a Spanish word, right? To again start to raise suspicion that this was actually a new drug. There was something unusual about it, and to associate it with the Mexican population, even though they had some of the lowest rates of marijuana use and were not using it in a widespread way. And Harry Anslinger was quoted as saying, there are 100,000 total marijuana smokers in the US, and most are Negroes, Hispanics, Filipinos, and entertainers. Their satanic music, jazz, and swing result from marijuana usage. This marijuana causes white women to seek sexual relations with Negroes, entertainers, and any others. And so as we started to see this kind of discourse increasing again, associating a substance with a very particular population, it led to the passage of the 1937 Marijuana Tax Act, which required any user to register themselves with the state if they wanted to use that substance. And it again was a way to kind of narrow the pool of people who were using, because people would not want to report themselves as using, and also to kind of make themselves known to entities for their use, right? So again, this was a tactic to start to kind of restrict access to this substance as well. And what we saw was that eventually this was ruled unconstitutional because it required people implicating themselves. But later marijuana was eventually folded into the Boggs Act in 1951, which created the first mandatory sentences for people found guilty of possessing any drugs in violation of state and federal laws. And in 1956, the Congress passed the harshest federal drug legislation to date, the Narcotic Drug Control Act, which created minimum prison terms for up to several years and allowed for longer sentences in the case of multiple convictions for drug possession. So we started to see that the drug war had already begun, and those who were starting to fall into the harm reduction gap were on their own to navigate an increasingly unpredictable drug supply if they weren't able to get forms of these substances through legitimate medical forms, and as that became more and more difficult to do. And, fast forward to the 1970s when many of us think of the drug war starting. But as you can see, we've already been laying the foundation for restricting access to these drugs for some time, and also ramping up penalties as well for violations of people using some of these substances in non-sanctioned ways and in non-sanctioned forms. And so this is when we saw the passage of the Comprehensive Drug Abuse Prevention and Control Act into law. And what made it interesting, and when he passed this, when this finally passed, is that while it did entrench penalties once again, and if anything, it rolled back some of those harsh penalties from the 50s, it also, though, was very notable in being the first federal bill that, while it did include federal penalties for possession and sales and manufacture of these drugs, it was the first time actually the federal government also funded for treatment, prevention, and research. It was the first time federal block money was made available to states to open treatment facilities, and to say that drug treatment should be available for people who might have addictions, as a way to kind of help address drug-related problems in our communities. This was also when the idea that we needed drug prevention in the schools was integrated. This idea that if we can nip it in the bud from even starting, we won't have as many drug problems as a society. So let's develop the treatment infrastructure to help people who need treatment because they have problems. Let's develop, a prevention system so that we're preventing young people from ever initiating these drugs. And then let's develop a research institute where we're funding research to better understand these drugs and what they do in the body. And again, this is all very important stuff that came out of the Controlled Substances Act that we often don't talk about enough. And that infrastructure that it laid actually is still in place to this day, right? The National Institute of Drug Abuse that was first funded because of this is still in place, and they fund over 80% of the world's drug research. We still use federal block money to fund our treatment infrastructure in many states that don't have enough local and state funds to be able to pay for that sort of thing. And, drug prevention continues to be something that the federal government helps to support. But the other thing that happened with the Controlled Substances Act is we further entrenched this divide between allowing carve-outs for certain forms of medical use, but then also deciding and drawing the line where there were certain forms of use and certain forms of drugs and certain conditions of use that would be criminalized and punished. One of the things that it did was create the scheduling system that was meant to develop and determine penalties for drugs based on, first of all, whether that drug had any medical utility, but on the other hand, the degree of abuse potential that that drug carried. How addictive was that drug? And so this idea was that we would put drugs on a schedule 1, 2, 3, 4, and 5, with drugs with the highest penalties as schedule 1, drugs that had no medical use and high addiction potential, but drugs in schedule 2, 3, 4, and 5, like cocaine and methamphetamine, and certain other drugs that have certain kinds of medical uses, but have some degree of risk for addiction, so that they can be prescribed by doctors or used in very restricted settings, but if used in ways outside of that, could still also be associated with penalties, right? And what happened was, though, that drugs that fell into Schedule 1 included marijuana, LSD, psilocybin in the list alongside heroin. And while obviously we knew that heroin came with addiction risk, we've talked about that already, drugs like marijuana, LSD, and psilocybin were placed in Schedule 1, even though actually, as many of us know now, many of us live in states where there is legal access to medicinal marijuana. We know that that you know CBD can have anti-inflammatory effects. We know that when in people experiencing wasting for HIV, that actually cannabis-derived medications can actually help improve appetite. So, we have access to medical marijuana, and increasingly, many of us are living in communities where there are more clinics where psychedelic-assisted treatment is available. So why was it that those drugs, which actually have low risk of addiction and high medical utility at the time, were made Schedule 1? In an interview with President Nixon's right-hand man, John Ehrlichman, we heard a little bit more about some of the decisions that went into this. You want to know what this was all really about? Nixon had two enemies, the anti-war left and Black people. We knew we couldn't make it illegal to be either against the war or Black, but by getting the public to associate hippies with marijuana and Blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. Did we know we were lying about the drugs? Of course we did. And so we have to acknowledge that, again, while in theory, creating a scheduling system makes a lot of sense. Sure, we should have different degrees of control and different levers to allow access for less risky substances in certain situations, and to be more mindful of more risky substances in other situations. It was clear that actually very little research went into developing that classification for the drugs that ended up in Schedule 1. But the other thing was that we said that it was about medical utility and abuse potential, but who did we give the authority to enforce the Controlled Substances Act to? We didn't give the authority to a scientific body. We didn't give it to a regulatory body. We didn't give it to a health entity. We didn't form some sort of new entity to make sure that the research was up to date about medical uses of these drugs and potential addiction potential for these drugs. We put the authority of enforcing the Controlled Substances Act under law enforcement. We eventually started the DEA, the Drug Enforcement Agency, and we put the authority of dictating what was a controlled substance and what wasn't a controlled substance. with law enforcement, not with a medical or health entity. And so we started to put this idea that drugs were a law enforcement issue, even while at the same time there were certain elements that were of the 1970 Controlled Substances Act saying that we should treat people who have addictions to these drugs with treatment. On the same hand, we were putting the enforcement of our drug laws under law enforcement rather than a medical entity, right? So this was the beginning of kind of already showing that we were making some choices in terms of criminalization and carve outs for certain forms of medical use. But then again, also choosing the drugs that had the harshest penalties to associate them with certain other groups, right? And the other thing that happened was while we criminalized the drugs, one thing that happened was that we still saw a proliferation of like head shops, places where people could buy bongs and pipes and other things like that because they existed in this legal gray area. While certain states had started to pass laws, even as early as the early 1900s, to restrict access to syringes, for instance, to people only with a prescription, we kind of had a variety of other items, drug-related items, that were often in a legal gray area, and in not every state criminalized syringes. And parent groups were very concerned about the proliferation of head shops that existed in their communities. And it was a multi-million-dollar industry that mail order, you could go on a mail order catalog and order various types of equipment to use drugs. And this is a real image from that era of a head shop owner. And so a lot of families and parent groups were saying, well, here we are criminalizing drugs, but there's a head shop on my corner. What message is this sending to my children? And so through their advocacy, states started to pass laws that would outlaw head shops. And head shop owners were able to fight back when they were arrested because they said, hey, I don't know what someone's going to smoke this in this pipe because in theory, someone could smoke tobacco out of it. So they were able to like actually fight back against some of these these so-called paraphernalia laws. And so then eventually by 1979, the DEA got involved and they said to the states, we understand you're having an issue with these shops opening up. So we're going to do you a favor. We're going to give you a model bill that you can just copy paste into law in your jurisdiction. And we will create the umbrella term of paraphernalia to encapsulate drug-related using equipment and tools. And we will create a bulletproof policy that if you institute this, you can then capture all these people who are trying to come through all these loopholes and you won't have a problem. And you can now start arresting people who sell these tools, but you could also arrest people who use drugs who have these tools on their possession because they should not have them, right? So we went from criminalizing the drugs now to criminalizing the tools. And so the 1979 Model Drug Paraphernalia Act defined drug paraphernalia as all equipment, products, and materials of any kind which are used, intended for use, or designed for use in planting, propagating, cultivating, growing, harvesting, manufacturing, compounding, converting, producing, processing, preparing, testing, analyzing, packaging, repackaging, storing, containing, concealing, injecting, ingesting, inhaling, or otherwise introducing into the human body a controlled substance. And so under this act, all of these items, if you copy pasted this language into your state law, now under this act, you could go after these head shop owners. You could go after anyone who is selling these things, but you could also go after any user. And this is where we started to see states now on a widespread scale criminalizing syringe possession, right? Criminalizing crack pipes, meth pipes, criminalizing the tools to test drugs with. And this would come to hurt us all a few decades later when the HIV crisis exploded among people who injected drugs because they were sharing syringes and they weren't able to get sterile ones. But it also came back and hurt us in this moment where now we have high rates of toxic and unpredictable drugs, and people in many states can't use fentanyl test strips or xylazine test strips or use advanced drug checking because that's criminalized, right? And so it meant that when the HIV crisis started, many of the first syringe service programs were actually breaking state laws, and people, advocates were getting arrested who were trying to save the lives of people who injected drugs by saying, like, we know that if you use a sterile syringe and a new syringe every time, you won't get yourself or your other friends sick. And it was the beginning of like why the HIV crisis exploded among people who injected drugs. And it was these laws that many harm reduction advocates had to advocate against to carve out the injecting language, or to carve out eventually the drug checking language so that they could give out fentanyl test strips during the overdose crisis. And then fast forward to the 1980s, the crack era, when we saw again the proliferation of more funding towards drug enforcement for crack. And then we saw the passage of the Crack House Statute, which then made it illegal for people to congregate and use drugs together in spaces. And it went after landlords who had property where people were knowingly consuming drugs on site, right? Which is the bill, or which is the law that has been used against overdose prevention centers from opening and being able to provide spaces for people to use drugs on site, but also get connected to services and care. And so the creation of the harm reduction gap was because we criminalized drugs and the tools to use them so that we made it harder to stay safe. But we also funded abstinence-only treatment and abstinence-only drug prevention through this idea that we would somehow eliminate drug use without acknowledging that, like, people can live in that gray area of using drugs occasionally, but our drug war never allowed for recreational drug use or social drug use. And that we can't close the harm reduction gap without kind of overturning policies that punish people who use drugs, or changing kind of our broader framework for drug use. And so I argue that in order to close the harm reduction gap, we need to kind of, beyond this idea of abstinence-only treatment and abstinence-only prevention, we need to think more about accurate drug education, including how to respond in an emergency, how to know when someone's use is out of control, how to have conversations with someone who might be engaging in risky drug use and talking about how to stay safe. How do we make sure that there are comprehensive harm reduction programs so that all the tools and supplies you need to use a drug are sterile and new and not being shared and used by other people? And outside of the, criminalization of drug paraphernalia, how do we make sure that people are staying safe? How do we make sure that we have overdose prevention centers where people can use drugs on site and get connected to services and have someone respond in case there is an overdose or an adverse effect? How do we incorporate harm reduction principles into therapy so that if someone walks in the door of a treatment facility and says, I'm not sure if I want to abstain yet, but I am interested in thinking about how to cut down. And how do we help treatment facilities become more accepting of people with non-abstinence goals? How do we also potentially develop an infrastructure outside of just AA and NA as the support groups, where people have to be abstinence-based to be able to get that mutual aid support, to mutual aid groups in the community where people can talk about their drug use and give each other tools and strategies to stay safe and get support as they try to navigate reducing or cutting down or being safer. And then also, like, how do we help people navigate the unpredictable drug supply through a safe supply of drugs or through more advanced access to drug checking? And so I know I've gone a little bit over, but I do want to stop for questions.
Thank you so much, Sheila. And you didn't go over, but I do know that you had to. You have a commitment. So I wanted to just make sure that you were there. It was a really wonderful presentation. I appreciate your compassionate approach and all of the historic framework that you brought into how we got to where we are today, as well as options for the future. We did have a question, as you saw earlier, from Michelle Berger, where she
Mhm.
asks, to what extent was the Chinese use of opium linked to the opium wars of China? Is it possible that the US government did not want the country to have widespread addiction, like what happened in China?
Mhm.
Is smoking it more addictive and dangerous than the medical tinctures, or was that purely political?
Yeah, so great questions. So yes, so there is a whole political history behind um, how, why, and under what circumstances Chinese people were introduced to opium smoking specifically. Actually, that was a practice introduced by the Dutch, which is a whole other piece of trivia and history that we could get into. But yes. So like the recreational use of opium among Chinese folks was definitely something that led to the Chinese government kind of making some declarations and engaging in the opium wars. Absolutely. Like there were concerns about opium use in China, and the government decided to take that strategy. Is it possible that the government didn't want this country to have widespread addiction? So we already had widespread addiction. We had 250,000 people who were addicted to opiates at the turn of the 20th century. Yet at that time, there was no interest in banning opium access for the American public. In fact, it only motivated the introduction of the Pure Food and Drug Act in 1906 because they wanted patients to actually know what they were consuming and how much, and then it led to the introduction of the FDA. So actually, all of that was actually helping American opiate consumers to become safer and more knowledgeable. So it wasn't that we were banning anything. If anything, we wanted to let them know what they were consuming. And so when the first opium ordinances were passed, they were passed specifically for smoking only, and then eventually for non-medicalized purposes again. So they still wanted Americans, even ones who were addicted, to be able to get access, and they still wanted them to know what they were consuming. So it wasn't motivated by fear of widespread addiction at the time. Is smoking it more addictive and dangerous than the medical tinctures? So at the time, before the Pure Food and Drug Act, people were actually consuming medical tinctures that had unknown potency because there was no regulation or oversight. So it's hard to compare whether or not the opium smoking was more addictive than the tinctures, because even the tinctures weren't properly regulated. So I can't say for sure whether one was more addictive than the other, because at least for opium smoking, you had to do it at a den. With these tinctures, you could take them home. And so like that was unregulated use happening in people's homes as well. So the risks associated with that was something that also couldn't be tracked, right? Any other questions or comments?
No, yeah. Well, I think, I saw Janie was, shocked. I think I definitely learned there were some histories that I knew, but others that I wasn't as familiar with, particularly like, the Bayer branded heroin.
Yeah, they made it.
So I learned a lot. I see Michelle saying thank you here. I've had other notes thanking us. So I want to join them and thank you so much for coming and sharing your book. Everybody, please check it out, whether you're buying it or checking it out at the library. And if you have the opportunity, yes, exactly. Well, the library's going to see if we can get the audiobook. And then you can hear Dr. Vakharia reading it again. So thank you so much.
Sure. Thank you.
Have a
Bye.
wonderful evening. Bye.